As mentioned, I'm the director of the Georgia Newborn Screening Laboratory, and we've been screening for X-linked adrenoleukodystrophy since May of 2020. So just as a state overview, my laboratory in Atlanta screens for all of the conditions from the blood spots for newborn screening in Georgia. And currently that is everything that's included on the RUSP at the federal level. And we have an ongoing pilot study for Krabbe disease as well. Follow-up in our state is mostly done through Emory University. They do all of the conditions except our hemoglobinopathies follow-up and our bedside tests. So hearing and CCHD are managed through cardiology departments locally typically, and then hearing is run through the Department of Public Health. Most of our initial follow-up, if the baby is a healthy term newborn who's going home at 24 to 48 hours, is done by the pediatrician or primary care provider, unless it's an emergency where we're essentially directing the family to an emergency department immediately for things like galactosemia, potentially MCAD in some of those cases, or a NICU if the baby's still inpatient. They do the initial clinical evaluation. Does the child look well? Do they have any symptoms? And then also we direct them to order follow-up testing as possible by the baby's insurance, where they're set up for doing draws and all of the kind of general local requirements. As a cliff's note for our XALD protocols for outpatients, inpatient is a little bit different because we're not typically expecting ALD if the child is still inpatient. The primary care provider orders very long chain fatty acids. We have labs we recommend because we do find some reference ranges work better than us. A lot of it comes down to insurance and contracts and who that particular facility is affiliated with. So because the program doesn't pay for it, we are somewhat limited as to where they send it in terms of their particular practices. If it's abnormal, or if after trying all of the follow-up tricks that our team has, getting this drawn seems impossible, then the child is referred to genetics. And if it's normal on a draw that is done by the primary care provider, no issues with that, that case is closed as normal. So we've done 2 stages of XALD screening in Georgia. We did a pilot initially that was NIH funded, that was finished in 2018. The testing was performed in an outside laboratory, but we had a similar structure. We did first tier flow analysis of LPCs, and then we did second tier chromatography analysis of LPCs to reduce our false positives. We screened approximately 50,000 babies. We identified 1 case of XALD in a male, 2 cases of proximal biogenesis disorders or Zellweger syndrome. Those incidence numbers make no sense, but it's a small number, so we kind of just rolled with it. You would expect more ALD, less biogenesis disorders, but again, on 50,000 screens, it seems like a large number, but when you're screening everybody, it's kind of a small number. So this provided the basis for nominating XALD to Georgia's Newborn Screening Advisory Committee. In Georgia, we have a state advisory committee panel that basically makes the recommendations, evaluates nomination, makes the recommendations, and then that ultimately is either approved or rejected by the Commissioner of Public Health. And that's how conditions get added to screening in Georgia. And we started screening all babies for XALD May 28th of 2020, which was kind of right as we planned, despite everything else that was going on in 2020. First tier testing is done with the Neobase-2 kit from PerkinElmer. It includes C24 and C26 lysophosphatidyl-cholines, or the LPCs. We only use the C26 in our overall algorithm. We've kind of collected data on C24. We're not running into any major algorithm issues, so we haven't really flexed our muscles on that. Our flat cutoff or referral to second tier testing is 0.44 nanomoles per mil on that first tier test. Our second tier testing, we developed a laboratory LDT, or laboratory developed test, because there's really no good kit available with the chemical terrorism unit in the Georgia Public Health Laboratory. They have more experience in chromatography. They have a bit more method development experience than is present in the newborn screening laboratory. And they also had instruments that had capacity. So this was kind of a chance to do some cross-lab collaboration, get some different hands in. And we were hoping this model kind of could be expanded, but we use HPLC tandem mass spec to separate I think a lot of people have talked about that kind of unidentified interfering substance. And at this point, the specimen is abnormal if our second tier test is above 0.3 nanomoles per mil. And abnormal first tier plus normal second tier is a normal screen. We do not report that out. We do not ask for a repeat. So that screening result is normal. And just as kind of our overall numbers go, we started on May 28th. As of January 1st of this year, we've screened 234,606 babies. We have referred 1,800 of those screens for second tier testing, so a shade under 1%, which is kind of where we thought, we kind of planned on 1%. So we're in that ballpark. It varies, but it seems like it'll probably end up somewhere between 0.75 and 1% with this strategy. We've reported as abnormal 28 of those screens. So it's 0.01% of all screens and 1.55% of the screens that we've referred for second tier testing. 10 of these abnormals were female. There's been 1 confirmed positive of a biogenesis disorder. 18 were males, and we've had 14 confirmed positive in the males, 3 biogenesis disorders and 11 X-linked adrenoleukodystrophy. In terms of overall newborn screening laboratory performance, this is one of the better performing tests that we have. Positive predictive value strictly for XALD, which is the condition that we added to our newborn screening panel. Just a shade under 40%, which is pretty good. For all potentially clinically significant peroxisomal biogenesis disorders, over 50%. So we're very happy with our laboratory algorithm, which is kind of why we haven't done a whole lot of tweaking to look at that C24 LPC or anything else. It hasn't been anything that we really needed to adjust due to any overlaps. Outcomes after they've been referred. So this is kind of looking at that 28 as a group at the screening stage, and then after they've come to genetics, if they came to genetics. So initial very long chain fatty acid analysis by the primary care provider, 9 of those screens were resolved as normal by that point. 2 of the children who had biogenesis disorders were never discharged from the NICU. Their diagnosis was confirmed by very long chain fatty acids and molecular testing while they were inpatient, and they had clinical findings suggestive of a biogenesis disorder. We had 2 patients who were lost to follow-up. 1 home birth that was reported to be XALD, but there was no kind of supporting information. We've included it as a confirmed case because they seemed convinced, but we're not particularly interested in engaging with the system. And then we have 1 unresolved case. So that's right now lumped in as our loss to follow-up. And so we've referred 15 children to genetics, either because they couldn't get that initial very long chain fatty acid done at their primary care doctor or because it was abnormal. So of the 4 females that were referred to genetics, 2 were discharged as normal. Their newborn screening result was a false positive. This is based on the very long chain fatty acids that were done by genetics and molecular testing of ABCD1. 1 was lost to follow-up after an initial visit, and 1 was diagnosed with a milder biogenesis disorder based on very long chain fatty acids, liver testing, and molecular analysis of the PEX genes. And then we had the 11 males who were referred to genetics. 1 was confirmed to have ALD at an out-of-state clinic. We have no further information on them. They're followed out of state. 9 confirmed to have XALD, very long chain fatty acids, and molecular confirmation of ABCD1. And then we have 1, again, a milder biogenesis disorder confirmed by very long chain fatty acids and molecular testing in genetics. So those are kind of our overall outcomes and how the children reached their resolved case status in our newborn screening system. And there is really only 1 genetics center in Georgia. So basically, if you're going to genetics in Georgia, you're coming to Emory. But we do have some children who are born close to a border who might follow up out of state, depending on their insurance and their capabilities. So that's kind of where we have those out-of-state ones who may not follow up with us. So confirmed totals over our 236,000 screens, 4 biogenesis disorders, 1 female, 3 male, 11 X-linked adrenoleukodystrophy, 0 females, 11 males. And our incidence, these kind of line up fairly well with what you'd expect to be published, which is nice. Maybe a little high on biogenesis disorders, but certainly within the published ranges. So 1 in 15,000 for any clinically significant biogenesis peroxisomal disorder. 1 in 21,000 for XALD for all births, and 1 in 10,000 for XALD in the male population that's screened. And this is pulled from our newborn screening cards. And I think Joe talked earlier about the potential reliability of that information that's submitted on the cards. The count is probably pretty close. It just might not be every single screen. A few years ago, we did a kind of accuracy study to say if we compared newborn screening cards to birth certificates, how accurate is that information? And we found about a 2 to 3% error rate in gender on a newborn screening card versus a birth certificate, and 18 to 25% errors on race and ethnicity on a newborn screening card compared to a birth certificate. So if we're holding up birth certificates as the gold standard, there definitely will be errors if we start relying too heavily on screening, not screening based on what is submitted on a newborn screening card. And then our incidence of biogenesis disorders, just a shade under 1 in 60,000. Notes from our follow-up team. So we currently are following 9 males with ALD identified through newborn screening by genetics at Emory. Typically, we do molecular confirmation through Invitae. They've been very good with insurance coverage, presumably including Georgia Medicaid, because that's fairly common. And they've also had a pretty comprehensive program for following up, both for familial testing as needed, and also reclassification of uncertain variants recently with appropriate supporting evidence. So that's kind of encouraging, because these are cases that could be challenging to follow up without some of that, particularly if you want to start testing out into the extended family. There have been no affected siblings identified to date, older or younger. None have been referred for transplant, which isn't surprising. Our oldest patient identified is still less than 2 years of age. So that's not surprising. A little over half of the moms have agreed to be tested, and also a little over half of the males have an abnormal ACTH but normal cortisol, and they're not currently being treated. However, one did require treatment during an emergency treatment during an intercurrent illness. So having the information about their diagnosis certainly has been able to help at least this one kiddo fairly early on in life in Georgia. 2 of 9 have not followed up with endocrinology yet, or it hasn't been documented with genetics. Again, pandemics made a lot of that challenging, and we do have some fairly recent diagnoses in this group as well within the last couple months. So I think follow-up is just kind of something that we're going to have to keep an eye on long-term to see how it all progresses. As our kind of overall take-home for our screening in Georgia, we've been really happy with how our screening has worked. One of the things we're always concerned about is overwhelming or flooding our system with either false positive results or uncertain results, and that hasn't been a significant issue here. We did like our screening model working with some of the other labs in public health. We've been pretty excited about potentially using that for additional second-tier testing to expand across our program. But those technologists who would have helped us out with that are also our backup technologists for our molecular testing, and they've been pretty busy for the last couple of years doing COVID. So those plans have kind of been put on hold, but it's certainly a model that has worked well, and we don't have a ton of cross-lab, inter-lab testing in Georgia, so it's been a model we've been pretty happy with. We don't completely eliminate our false positive results, but we also aren't flooded with false positive results, so we're pretty happy with how our testing is performing. Higher incidence than maybe we expected of peroxisomal biogenesis disorders, but we could go a year or two without seeing anything, and I wonder if our incidence might have just been underrepresented before we were screening, and some of these children were not being diagnosed at all before when they were acutely ill. So that's kind of challenging. One of the things that is certainly, observing our case numbers and the gender breakdown, we're almost certainly missing female carriers. And I think it's most likely in that population that are cleared by normal, very long chain fatty acids at the primary care provider. And because of how our screening is performing, we aren't urgently looking for making changes, but it's something I think we need to discuss to say, is this something that needs to be improved? Do we want to? And also, can we? Because when we added this condition to our screening panel, the condition that was added was very specifically childhood cerebral X-linked adrenal leukodystrophy. And so expanding screening panels to potentially look at a different condition or anything other than that, it's not impossible. It would just require probably a little bit of a discussion and explicitly describing what we're doing. This has been hampered a little bit to the extent that when X-linked adrenal leukodystrophy was added to the RUSP, they did not add Zellweger or any of the other forms as secondary conditions, as things you might detect. So we don't really have that kind of supporting overarching evidence. We do add our own conditions, but we very closely model what happens at the federal level as well. So it's been a bit of a challenge. I think it's kind of something we'll just have to monitor going forward and look at trends to see where we are. We definitely think, based on the instance of what we're seeing in males, we're certainly not identifying the females, but that doesn't mean we wouldn't detect any of them. So it's a little bit early to make any overarching decisions about how we might make any changes in Georgia just yet. But overall, it's been a fairly successful implementation. I think we've identified some children that are able to be plugged into the appropriate interventions, and we're satisfied with how our screening is working so far. I'd just like to thank my team at the Newborn Screening Laboratory. I couldn't do this without them, as well as our CT team, who, when we brought them a completely different test, sample, and mechanism of screening, we brought them all of that, and they were pretty happy to jump in with both feet and help us out. Angela and Gwen, our follow-up coordinator and the main genetic counselor who sees most of these patients, they were super helpful with our screening program and also with helping me put together this presentation. So thank you all for your time, and if there's any questions, I'm happy to answer them.
So I have a question. So you're having the primaries do very long chain fatty acids. Who's interpreting those? Did you hear the question?
No, I'm sorry. I think I must have had my sound turned off briefly.
Okay.
I apologize.
So you're having the primaries do the confirmatory very long chain fatty acids, and so some people are being labeled as normal. Who's kind of reviewing those? Is it
They
just
all
strictly? Go ahead.
So the primary care provider orders it. They are before the case is closed, those results are sent to the newborn screening follow-up program. So they are reviewed centrally. It's not that the primary care doctor is saying that it's.
I'm not saying they're so esoteric, but I don't completely. Yeah. Okay.
Yeah. Yes, we do review them centrally at our newborn screening follow-up program. So kind of the same small group of people would review everything, which is why some of those children, even if they did get testing at their primary care provider, still end up coming to genetics.
Mm-hmm. And I will also highlight that when New York started, and I don't want to speak for Joe Orsini, but when New York started, they had a high incidence of peroxisomal disorders also that just kind of fell away as the years went by.
Yeah, I think it's kind of hard to make a judgment on your first couple of years of screening because all it takes is 1 year of no cases and your incidence is right where it should be. So.
Yeah, no, I joke when I heard the first like 9 months, someone said, "Is that awfully high?" I said, "Wait, I'm writing my grants."
I believe May is next.
Yes, actually, Dr. Riemann asked the first question, but I want to follow up. So this is a kind of unique situation in newborn screening. You first let a primary care physician. So that the purpose is only you just order the very long chain fatty acids, right? So you tell them to order the testing, and they send the testing actually back to the newborn screening follow-up program. The newborn screening follow-up program, based on the very long chain fatty acid results, decide we'll get metabolic physician involved. Am I right?
Yes, that's how we do all our conditions in Georgia.
Okay, yeah,
unless we're referring them immediately to a hospital, that's been the only way. Georgia's a big state. Some of those kids, if you were saying you'd have to come to a hospital, it's a 5-6 hour drive. So If they can do the initial steps with their primary care provider, that's the best way for us to get it done.
Well, I feel that very intriguing because we may give us some food for thought. Second question I want to interestingly talk about the female, and we have a lot of physicians here, Dr. Raymond on here too. So if the female in the newborn screen stage, they truly have, normal, very long-chain fatty acid, and also it depends on your cutoff, you may not capture all the female carrier. Is that all right? I thought it's all right, but yeah.
I'm kind of two minds, which is, I think it's all right if we explicitly say what we're doing, what we're not doing, and what the consequence, like if everybody knows exactly what's going on and what we're doing and why we're doing it and how we're doing it. I think being upfront about we might miss some, yes, not targeting them. I think it's hard not to target them. Other states have found carriers. I don't think we've designed our algorithm explicitly to exclude them. We just haven't identified them.
Yeah. Well, yeah, I think it's why I like to talk about this, because we have a lot of parents, people here. I think I'd like to hear them opinions, because for the newborn screening purpose, is identified actually strictly, like you said, a cerebriform ALD. But because of the testing we do, because of X-linked disorders, we may pick up the female. I don't want to say carrier. So I think that's why the line you want to draw, and because the purpose is not to identify every female carrier, but I feel if they have elevated, well, I'm not so sure that's even right, but I'm going to say this for the discussion purpose. If they're, my mind even more think about actually Duchenne. If they do have the function marker elevated, indicated they have this, non-random excavation, they may justify to be picked up. But if we strict from the carrier point of view, and I just question on that. So
I think it's tricky also because identifying carriers through newborn screening has raised different hornets' nests in the past with CF in some regions as well, where people were not at all happy about that. So it's a little more nuanced than I don't think I have any sort of easy answer for that one.
thank you.
I'm not. Hi, I shared our personal journey earlier, so I just wanted to reiterate that catching our female carrier daughter is what allowed us to find our son was positive with XALD. So I think that was something that really benefited our family, obviously. I think also then it gives us the opportunity to plan for our daughter later in life as she may decide to have a family and the options that may be available to her. So I think it's a very interesting topic. I understand with the mission being kind of to eliminate the potential of cerebral ALD and that being the primary focus, but I think there is more to consider on that topic.
Definitely agree. And I did see your question. I don't know that there's anything specifically about our second tier testing that would eliminate positive females as opposed to positive males. I don't think there's anything biochemically different except for the degree of elevation. So that might be the only thing that we look at. It's not preferential except in the terms of the magnitude of the elevation.
Thank you.
Thanks, DJ. Dr. Kam, your hand raised.
Yeah, thank you for your presentation and the interesting discussion afterwards. I heard May say that you want to pick up child with cerebral ALD with newborn screening. As far as I know, there is no way to differentiate future AMN males from child cerebral LD based on C26 lyso-Pc levels at newborn. We cannot predict that. So you will pick everybody. I was chatting a little with Joe, and I think he just put it in the chat that I was going to answer the question. Last 2 years ago, we published a paper in which we demonstrated that women who can have you can have 50% false negatives in women. So you mentioned that you do follow up with verum chain fatty acids, and if it's a normal result, then it's no ALD. That is not completely safe, of course. So I'm just suggesting or wondering, why isn't this follow-up research not done with C26 lyso-Pc as well? Because it's superior to verum chain fatty acids.
Agreed. I do think part of it is clinical availability, in terms of what we can feasibly get done. I also think it's a balancing act in terms of what we are trying to find as well. So based on, state mandate and what we are tasked with doing versus what potentially our ultimate best case scenario is. And I think that's a broader discussion that I don't think we overall had when the condition was added to our state screening panel.
Yeah.
And I think that kind of got missed at a lot of levels because, again, there was really no guidance around females or biogenesis disorders at any of those levels. It was, you should screen for ALD, and it's kind of been a little haphazard as to how everybody's put that together and implement and operationalized it.
Yeah, the only danger, of course, is if in the 1 out of 6 cases in which you would say it's not ALD, the family gets a message that our daughter doesn't have ALD. So in the differential diagnosis, when one of the cousins or brothers start behaving signs, then ALD is technically excluded. So that is the downside of it. I mean, I fully understand what you say about it wasn't set up to identify girls with ALD, but that's the downside of it.
Oh, I agree. There's absolutely downsides to it. And I do think that's why I think what we're doing, the goals of what we're doing and how exactly, like, there are positives, negatives, and in-betweens to all of the decisions that we make as far as a screening program goes. And I do think that's one of them. But I also think that there's been pretty strong advocates that say a screening program should benefit the person being screened, and that should be where the primary benefit lies, not potential out of stream effects. And that's a different viewpoint.
Yeah, I understand you, because we had to do a boys only screening. So
yeah, exactly. So
what I'm meaning is that not an ethical discussion, but more that if the family gets a message that their girl does not have ALD and it turns out to be a false negative, then ALD is excluded, but you can still have ALD. So that's what.
Well, I would argue that no, a screening result is a screening result, and if you have a clinical suspicion, that should be followed up aggressively. We tell our providers that about newborn screening results all the time. If we told you that child doesn't have galactosemia and you think that child has galactosemia, you need to test them and stop milk intake. So it is a screen.
I think at least in the US, we're very far from people. I mean, because we still have women that get diagnosed and the doctor says, no, that's not why you have spastic paraplegia.
Yeah.
So I think in the US, at least, I think we're so far from that I think I wouldn't worry so much about that. But I do think that the girls, I worry that we make it too much only about their childbearing. We saw patients today in clinic, and the most severe one we saw was a woman. We haven't recognized these women, and some of them we've written off as having other diagnoses. And so I think it's important that we just also remember that, so often we're telling moms, that they need to focus on their own health and not worry only about their kids. But so I worry, and I do this myself, that we're sending the wrong message to them from a young age, that this information is only important for future kids, when really we don't know that. It might be very important for their own health. But again, I do the same thing. And as a mom, I do the same thing. So I'm preaching to myself.
So Tricia, out of the 9 females, are you saying that the families were not told that they were positive? I'm confused.
Oh, no, they were told they had an abnormal newborn screen that was abnormal for X-linked adrenal leukodystrophy. That was reported and it appeared on their report, and they were followed up by their primary care provider, and they had access to Emory follow-up if needed. So it's not that they weren't told anything.
Okay, so they do know. So if they do have siblings or extended family, they can test them. It's not that you're not telling them.
No, we do tell them.
Got
Yes.
it.
Yeah, it's on their newborn screening report, which presumably is in the child's medical record. And yes,
I thought we are talking really is the program may not identify all the female carrier. That's the
Yeah.
topic we are talking.
we definitely might not. I think I would acknowledge that.
Okay, thank you so much for fielding all those questions. That was a great, lively discussion. Oh, we do have one more. Hi. Dee Friedenberg. You're on mute. You can unmute, and then I
Hi.
think.
I'm Dr. Friedenberg, and I'm with the Texas Newborn Screening Program. And we face all of those issues that all the newborn screening programs face. But I think that when you look at an X-linked condition and you talk about carriers, and we know that there's a potential that there's, well, whatever you want to call it, manifesting carrier, you want to call it affected, whatever you call that, you're in a whole different position. And, we have found that we have identified a number of females that have one copy. And we have found, obviously, other family members and other first cousins who are at risk and who do, once they get that evaluation, do wind up in medical care and need to be followed. And some are manifesting. And we have stories of grandparents that have been diagnosed with something else. So I think it's different than when they referred to CF. It's a very different thought process when you're looking at an X-linked condition that can impact many family members. And it's not just, as you say, a reproductive decision as well. Now, our screen is a little different. I mean, we do the initial C26, and then we do a LPC C26, and then we go to sequencing for our program. I mean, and we're still not going to get, we're not looking for the female carriers, and we're not going to get it because that 30% that the LCFA on the initial screen is normal and would not reflex to further testing. But I don't think you can just say it's in this condition that it's a carrier and, so be it. We're a newborn screening program. We're not going to do anything with it. So that's just my philosophical thoughts.
No, I agree. I just think I think it's a part of the discussion that I don't think it's been talked about, but I don't think it's been fully pulled apart and addressed with the best practices of how do we do it.
Right.